Hello, everyone out there who's interested in hearing about dental therapy in Canada. I am Leslie Topola. I've been a licensed dental therapist for 50 years in Saskatchewan, and this is my story of the Saskatchewan Dental Plan. I did this PowerPoint for the Saskatchewan Dental Therapists Association scientific session on Saturday, April the 27th. This is the full comprehensive presentation, and it represents a good chunk of my working life. All the references that I refer to in this PowerPoint are listed at the end of the PowerPoint. They're also all available on the website of the Saskatchewan Oral Health Coalition. You can just Google that, and if you go to resources, and under resources, there'll be a tab that says History of the Saskatchewan Dental Plan. All the references I use are there. And I also wanted to reference just before I start that I am doing this in Saskatoon, which is on Treaty 6 territory in the homeland of the Métis. I have heard a history of the National School of Dental Therapy, and I feel that dental therapists at the National School of Dental Therapy, or Federal School of Dental Therapy as some people call it, and the training we had at Wascana Institute in Regina is similar. And I think many of the challenges we faced in the early years were similar. That said, the Saskatchewan Dental Plan had a short life, a very important short life, whereas the National School of Dental Therapy went on to train dental therapists for 39 years, which is very impressive. But sadly, politics interfered with both of those programs. And that's the story I'm going to tell you today of the Saskatchewan Dental Plan. So you need to know that the Saskatchewan Dental Plan didn't start in a vacuum. There was a lot of socialized medicine happening within the province over the many decades before the dental plan came to be. So municipal doctors were establishing union hospital districts in the 1920s. And in the 30s, municipalities were putting in place tax-supported health insurance programs. And in the 40s, Swift Current even started their own Medicare program, and it included dental services for children, which was very unique, children up to the age of 18. And I'll just note here that that continued on in place well into the dental plan years and eventually was rolled fully into the dental plan. And if you live in Saskatchewan, you probably have heard of Tommy Douglas and his struggle to achieve Saskatchewan-wide universal health care, not only Saskatchewan, but it came kind of across Canada. And that is the context with which the Saskatchewan Dental Plan was born. So in 1962, the government of Saskatchewan sent representatives from the College of Dentistry and the Department of Health to New Zealand to observe its dental nursing program because they had heard about it and they thought that that was what they wanted to have in Saskatchewan. By 1964, a report had been issued that attempted to address some of the shortage of adequate dental services in the province of Saskatchewan because there were few dentists and oral health was very poor. In 1966, the government of Saskatchewan, the Department of Health, set up a dental advisory committee, an ad hoc committee on dental auxiliaries, and that did include dental assistants and dental hygienists. At that time, the assistants and hygienists were under the umbrella of the College of Dental Surgeons of Saskatchewan. In 1968, each committee submitted their own report to the Department of Health as to what a dental plan could look like. And from that, the Oxbow project was organized as a pilot project with federal funding and also provincial funding to pilot dental care services for children aged 3 to 12 based on a dental nursing model. So they did hire dental nurses from the United Kingdom to come, 2 of them, and they worked using four-handed dentistry with 2 dental assistants and a dentist, and they provided excellent services to the children in and around Oxbow. They operated kind of out of several trailers. So that pilot was a resounding success and was used as a foundation for the dental plan. In 1971, there was a significant change in government and the Democratic Party was elected. And one of their healthcare promises was to provide an insured dental care program for children up to age 12. And they delivered on that. Imagine that, politicians delivering on a promise. They actually wrote a proposal called A Proposal for a Dental Program for Children in Saskatchewan. In November of 1972, it was published. And just as a side note here, which I find kind of interesting, I was in the very first class of dental nurses that was trained at Wascana Institute of Applied Arts and Science, and had already been in school since the end of August. So they knew that they were going to go ahead with this. They were already training us. This was just the basic plan that they were sharing. They noted in the report that the dental health of children in Saskatchewan is poor, and they said it is clear that a bold and imaginative plan must be designed to attack the health problem, and that the public, the dental profession, and the government must act cooperatively and deliberately to meet the dental need challenges in the future. So just how bad was the oral health of children at that time? Well, age 7 children, 76% of them required fillings, 39% required extractions, and they had an average GEFT of 5.5. Age 11 children, 75% of them required fillings, 26% of them required extraction, so that's a lot of teeth. And their average DMFT was 4. And I just pause here for a minute because a DMFT of 4, age 11, you might have possibly 12 permanent teeth, and you have 4 of them that on average are decayed. So that's not good. Also in 1971, there was only 185 practicing dentists. In half of those were spread between Regina and Saskatoon and only served 30% of the population. So that has improved slightly in 2024. We know we have now 495 licensed dentists, and the ratio is 1 dentist to 2,500 people in Saskatchewan. But conveniently, they're still kind of located in all the urban centers. So Regina, Saskatoon, Moose Jaw, they aren't overly accessible in the rural areas. So access to care is still a problem in Saskatchewan, particularly in the north. There were high training costs. It cost $11,000 to train a dentist, $4,500 for a dental nurse, and $40,000 for a hygienist. And that doesn't seem like much now, but it was a lot in 1971. There was underutilization of private dental services by the public due to financial burden, economic conditions, and geography. So again, in 1971, there were not employer paid for dental plans like there are now, or Blue Cross. We were predominantly a farming community in 1971. So, if the farmers didn't do well, there was not as much money to spend on things like dental care. And geography, which really hasn't changed in Saskatchewan. It's still a fairly sparsely populated province, and consider the huge landmass of where everybody lives. So that's still a bit of a challenge today, even. In 1971, only 35% of the population of Saskatchewan had access to community water fluoridation. And by 2024, that's only a little bit improved. 39% has access to community water fluoridation. And I have this slide in here because in 1973, when the College of Dental Surgeons in Saskatchewan was responding to the government on their proposal, they wanted to have mandatory community water fluoridation for all communities. And now that sounds like a worthwhile goal. It's certainly scientifically sound. We do know it's still the most cost-efficient method of improving the oral health of everyone in the province, not just children. But really, in a democratic society that we live in now, and even then, that wasn't something that was going to happen. But it was a concept back then. Oh, and I did want to also add that the 39% of the population that has access to community water fluoridation in Saskatchewan now, that's going to increase almost by double in the next 3 to 4 years. The Regina City Council has determined that they will implement community water fluoridation when their new water treatment plant at Buffalo Pound Lake is opened, and that should be in a couple of years. And then Regina and area will have access to community water fluoridation as well. So stay tuned for that, because that's going to happen. So some challenges that the College of Dental Surgeons in Saskatchewan identified with the government's proposal. The main thing was supervision. A 1972 survey of dentists in Saskatchewan basically showed that 95% of the dentists wanted to have direct supervision. And that isn't, again, from the lens of private practice, that's how they operated, and that's what they perceived that the dental plan should be doing. But the dental plan was going to be a dental public health program, and dental public health programs typically operate on a population base, and they don't have that narrow lens of direct supervision. And the government of the day, as we know now, did not plan to have direct supervision. But the dentist felt that there were some really good reasons why it should be in place. And all of these particular categories are concerns that they had related to supervision. And I'm going to talk a little bit about each of them separately. Mandibular blocks were one thing that was identified as a concern if there wasn't direct supervision. And I want to be clear here. In Australia and New Zealand and the United Kingdom, dental nurses were not taught to do mandibular blocks. And in Saskatchewan, they did want us to do that, but they had a low threshold of trust and belief that that is something that could be taught. Again, if you read the report, and I'm just going to be clear, it's quite a paternalistic report, and it's written through that lens. And so there was a concern that, was this going to be doable or not? So everything that I have in the next few slides that's in quotation marks is directly out of the report that the College of Dental Surgeons sent back to the government. So it's quite possible until considerable experience has been gained to consistently miss mandibular blocks. Broken needles, the probability of this happening increases with the use of mandibular block technique. Young children will jump. That was the concern. It was moot. It never did turn into anything. The dentist can detect minor errors in technique and upgrade quality of fillings done. After a period of time, he could slowly delegate more difficult restorations to the nurse, thus increasing utilization. And in this report, the dentists were always he, and the nurses were usually she. They felt that it reduced the necessity of dual treatment when a dental nurse has a pulp exposure or difficult extraction, requiring the patient to undergo freezing a second time for treatment by the dentist. So they thought direct supervision, there was a pulp exposure or something that needed the dentist's intervention right away, the dentist would be there to do it. Again, it had already been determined in the curriculum that dental nurses in Saskatchewan would be trained to do pulpotomies, direct pulp caps, indirect pulp caps, crowns. We only extracted deciduous teeth, so there really shouldn't be that many difficult extractions, unlike the federal dental therapists who were trained to extract permanent teeth in simple extractions of permanent teeth. Emergencies was a concern. The legal and moral responsibility for effective prevention and prompt treatment rests solely in the hands of the able and informed dentist. It is very doubtful that a dental nurse with 2 years training will have any of the above capabilities to deal with emergency situations. And again, mandibular block was referenced. And again, this became a moot point. The dental plan did have arrangements for after hours and emergency care on weekends. And there was about 10% of private practice dentists in the province who were called upon in any given year to provide that. But there really wasn't any life and death situations that ever happened in the dental plan. There was a concern that there'd be severe hemorrhage after extraction. And again, clarifying that we were only extracting deciduous teeth. So again, in 2 years, the nurse cannot be expected to have any background in hematology or be able to truly understand blood clotting mechanisms, and therefore will be incapable of properly handling such cases. And again, that turned out to be not a concern. Productivity. With a supervisor on the premises and delegating work to the nurse, it is quite likely she will do more in a given time than if she can work at her own speed. The supervisor will also assume the role of personnel manager. And again, we were going to be working in a dental public health field. We were going to be employees of the government of Saskatchewan or Saskatchewan Health who had their own mechanism for human resource management and management of any issues. That was never going to be what the dentist did. Children's dentistry done properly is not easy. In fact, it is one of the most difficult and challenging areas in dental practice. And I think we'd all agree with that. And there was a lot of time and attention paid to us to be able to manage children well and to treat them well. And this was never really legitimately a concern. And it is interesting because today, 50 years later, it certainly is one of the attractive reasons why dentists will hire dental therapists, is because they know that they do very well with children. And really anybody who needs extra time and attention and patience, they do extremely well. And that's That's why there's such a bonus to private practice today as we speak. This was a concern in the 70s. It did not turn out to be anything to worry about. Attrition was a concern for the government as well. Again, it was in the 70s. There was a concern that because the majority of dental nurses, not all, but the majority were women, they might get their education, go off, get married, have children, and never return to the profession. That was sort of what was happening back then. But indeed, this did not happen. So the direct supervision should aid in keeping the attrition rate of nurses as low as possible. I'm not sure why. The constant encouragement and backup she will get as a result of direct supervision will help her to stick with it. And so this attrition rate was carefully monitored. And it was monitored from the beginning of the dental plan, 1974 to 1981. And they realized that the attrition rate had plateaued off at 18%, which was quite a bit lower than all the other health professions. They were expecting the attrition rate to be anywhere between 20 and 50%, which is large. But that never happened. And a lot of the people who went out of the active dental plan actually returned to be instructors at Wascana and SIAS. So it was kind of cyclical. So this was never a huge thing. And in addition, society was changing. Talked about socialized medicine in the 60s. Well, there was women's lib and equal pay for equal rights, and things like maternity benefits and other benefits like that were coming into play, where it made it attractive for women to have children and then return to their profession. And that is indeed what happened. So the training of dental nurses started in 1972 at Wascana Institute of Applied Arts and Science in Regina. So that was a shiny, nice new building there on the left. We went actually to this Wascana Dental Clinic, which was in the old Nurses Alumni Building beside the Regina General Hospital. And that's where we went to our dental clinic. That's where we went to school. And for most of the years of the dental nursing program, that's where it was. We didn't get to go to the larger building. And the first year and a half, pretty much, we worked around construction workers and walls going up and being taken down and construction dust or whatever. We went to school in basically a construction zone. And this is a picture of our student dental clinic where in the second year we did bring our patients up. It was all done in the colors of the 70s, so kind of golds and greens and oranges. There was right here is the central supply inventory area where our dental assistants would set up our instrument trays, do the sterilization and supply renewal. Again, another picture of the dental clinic. It's kind of live in action photographs of people. One of our Australian instructors with one of our students, and this was somebody in my class. And you can see that lovely, lovely sea of orange carpet. And that was quite common back then, and we didn't really think of it from an infection prevention control aspect. But of course, we know now today there's no carpet anywhere. But there was a lot of carpet. And orange, as you can see, orange is quite predominant in the color of the clinic there. And orange was actually the branded color of the dental plan. So my presentation is kind of a retro designed PowerPoint in oranges and golds and greens because of that. That was the kind of color of the day. Again, the lecture theater, the reception area where the kids came. Eventually, it changed from just being called the Wascana Dental Clinic to being called the St. John's Campus. So again, the College of Dental Surgeons' response to the government was that the profession won't settle for a substandard plan for Saskatchewan's children. We want the best. We want a plan that is so good it can and will be adopted as a model by other provinces and countries. In short, we want the best for our children, and we will not rest until it is attained. And guess what? They got that in spades, 100% across the board. In 13 years the dental plan operated, they absolutely attained that. And we do know from all the research that's gone on, still decades later after the dental plan ended, that there's a feeling that we were too successful and the dentists wanted to take that back for themselves. They thought that there was other opportunities that dental nurses could maybe be providing care and long-term care. We pretty much gotten a handle on the dental disease in the children, so where else could we go and what else could we do? And so there is a concern now that we were maybe too successful, and that didn't really help us in the end. So, but the College of Dental Surgeons did get this 100% what they got. And I did want to mention before I leave this, supervision being the concern of the day, that the first year that I worked in 1974 in the dental plan, there was an agreement that there would be direct supervision from September till the end of November, and there was. So we were actually divided all throughout the province of Saskatchewan. We were divided into groups of 4 or 5 dental nurses and teams to a dentist, and we had that direct supervision of a dentist for 3 months. And then come December 1st, we were on our own. We went to our own districts and did our own patient load. So the dental plan was established in September of 1974. Uh, and that was established through 2 mechanisms, the 35 dental nursing Wascana graduates and 19 dental nurses that were hired from Great Britain, because that's how many nurses they needed to staff the dental plan and instructors at Wascana in that particular year. So there were, the very first year, there were 11 dentists, 46 dental nurses, 64 dental assistants, and 5 dental hygienists, and 6 dental equipment technicians. So the dental hygienists over the years decreased, and I'll come back to this later, but eventually after about the 3rd or 4th year, there were no more dental hygienists, but they did make a resurgence later on, and I'll talk about that. So the whole concept of the dental plan was that a dental therapist and a dental assistant would work together as a team. They'd move from school to school, community to community, and they would provide all the preventive, diagnostic, and restorative services that the children that had consented for those services in the school had. They would provide everything that that child needed. And this, it did indeed occur. And the four-handed dentistry, now my class and subsequent classes early on, I don't think actually practiced four-handed dentistry in school, but it wasn't too complicated to catch on to. And certainly it was important to work as a team in the dental plan. It just made it more efficient. And certainly when you're moving things around and reestablishing yourselves, it was a good idea to work as a team. And that's what we did. All of these old black and white photographs I'm showing you are all out of the old Saskatchewan dental plan reports, and you can find them there. So in 1974, there were 215 permanent clinics. So it looked a lot like the one on the left side. With an 8-deck chair and stools and cart and water unit, chemiclave, etc. And the temporary one to the right, we transported all that equipment. So we'd taken an 8-deck portable chair, the stools, the portable compressor, the cart, the cabinet. The X-ray machine is the only thing that did not, or sorry, it moved all the time. If it was a permanent clinic or temporary, there were brackets on the wall that a wooden piece of plywood with the X-ray machine mounted to it was on, and you just slide the X-ray unit into the brackets, and it would be stable, and you'd use it, and then you'd slide it out and pack it up and move it on to the next school, and that worked very well actually. There were central dental clinics in Prince Albert, Regina, and Saskatoon, and Prince Albert was a little bit different how they operated because they had a 10-chair dental clinic in kind of the center of Prince Albert, and children were brought to that clinic to have their treatment provided. Regina, Saskatoon, we all, as dental nurses, we went to the schools and provided the treatment. And Victoria School, which this is a picture of right here, had a 4-chair dental clinic, as Regina did. And typically it was the dental plan dentist who worked in these clinics along with the nurse who had that school. In the first few years, because there was so few children, we would transport the kids from school to school. Just because it was just easier to take 2 or 3 children from a school and take them to another school to do their treatment. And then, you know, the next week you could go back and get them and do their treatment that way, because you couldn't do 4 quadrants of dentistry on 3 kids at a school all at the same time. That just wasn't even fair or even considered. So we all found ways around that. So this Victoria School Clinic was conveniently located up about 6 flights of stairs at the very top of the Castle School. So it was very, very accessible to people. There were 2 mobile clinics that were used in the early years. Again, good concept. They looked exactly like a permanent clinic. They didn't have air conditioning and they didn't really have good heating in them for the winter, and they froze up. So while the concept was good, and even today the concept is good, but they're not overly popular or functional for the most part. In 1974, we only saw kids in grade 1. We saw kids age 6 who were born in 1968. And then the next year, those grade 1 children moved into grade 2 and we saw them again, but then we saw kids in kindergarten in grade 1. And then we saw kids in kindergarten, grade 1, grade 2, grade 3. And they kept adding children. till eventually by 1987, we were seeing children from age 4 to age 16 or grade 11. And in the spring of 1978, they did add age 4 children, and that was as low as it ever went. So the dental therapist, dental assistant team, we moved from school to school in the G car, the government station wagon. We all, typically the dental nurse had a government station wagon assigned to them. And this one is white, but again, in the color scheme of the 70s, they were usually gold and green and orange as well. And we just went from school to school. So by the end of the dental plan, there were 578 permanent school clinics that had their own pedo chairs and lights and built-in compressors and cabinets, etc. And we just took our supplies there and did our work. Teaching resources used, there was a lot of homemade resources because there weren't the abundance of resources that there are today that you could either purchase or certainly online while the internet didn't exist. And so prevention was a key element to the dental plan. And Wascana actually had a prevention room where there was probably 3 rows of little chairs and sinks and mirrors. And we would take our patients in there and we would teach them oral hygiene. If the parents came, we would teach the parents as well. And it was a fundamental philosophy and value of the dental plan that prevention was done at all costs to everything else. And that is how we actually ended up preventing so much dental disease. So the next few slides are just from a PowerPoint that Saskatchewan Health actually made to promote the dental plan. So you're going to see some interesting things here. Okay, so no infection prevention control as we know it today did not exist. There were no masks or gloves. There was rings and watches and things like that, but processes were fairly similar. Good old fluoride treatment, and if you look to the right of the plastic fluoride tray, you'll see a piece of foam. And how we did fluoride treatments back then with our wonderful gel fluoride is we put the foam in the plastic tray and put the fluoride treatment in there, and the child would bite on it for a certain number of minutes. I want to say it was 4, but my memory doesn't serve me that well, perhaps. And when we took it out, we threw out the foam-lined gel part, and we washed off the plastic tray very well, and then it went in cold sterilization, and it was used again. So you can see that infection prevention control has come a long ways since then, and that just, even to say that out loud gives me the heebie-jeebies. I find it hard that we did that. Good old Calzinol was a good liner we used back in the day, and many of us swore by that. It was such a good liner. Again, watches, no gloves. Rubber dam, it was consistently used in the dental plan. We all knew how to put it on even the most difficult teeth. And I do believe in the end, this is one of the reasons why all our evaluations showed that we did superior fillings, is because we consistently used rubber dam. And we had more experience actually doing fillings than most of the dental students that came out of dentistry. So that's what our focus was. So we're all done in school. We pack up the G car and load it up with our supplies and equipment, and off we go to the next school. And the kids, they did look forward to us coming every year. And some people don't believe that, but they did. The kids knew why they were coming into the dental clinic. They'd hop in the chair, say hi, and away we would go. So this is the November of 1974, the dental plan. So kids liked the dentist. So there's a picture of a dental assistant and dental nurse, and I knew these people. I worked with them. So Gretchen was a dental assistant, Sean was a dental assistant, and they're working on 6-year-old Russell Shepard of 1415 2nd Avenue North, and he has a tooth filled by the dental nurse. And the teachers were happy with it. The kids were happy. And I read this now and I think, okay, well, it's not just infection prevention control that's changed. Look at all the privacy and confidentiality issues that are just in that 2 sentences that I said that don't exist today. But the dental plan was well liked by people, even in the beginning. The dental plan was always really good at doing evaluations and surveys, and it's what kept the quality high, and there's no doubt about it. And one of the first surveys they did was in 1978, and it was just a phone survey, and they found out that 89% of the families were satisfied in general with the dental plan. 40% of them recommended it to others, so now we would say, well, that's the equivalent of a like on Facebook. 80% wanted ages expanded, and of course it was still expanding in 1978. 50% noted that their children's oral health had improved, so they were brushing and flossing at home and they took better care of their teeth. 89% felt that dental nurses provided good services, and that was very high in the rural. 94% were satisfied with their handling of children, and only 2% cited dissatisfaction, and that was usually related to something related to do with pain. In 1981, it was a very big year for the dental plan. Many things happened. So one was that they started school-based fluoride mouth-rinse programs in 8 schools. And those fluoride mouth-rinse programs actually continued on in dental public health into the SHA up until 2018. And they were ceased because there was no longer an availability of fluoride mouth-rinse products. And so that changed into fluoride varnish that we provided, but they lasted a long time. And there was a whole promotional campaign about fluoride mouth-rinse programs. They also implemented an adolescent program. And the concept behind it was that once a child reached grade 8, they didn't want them to just stop their dental care. They wanted them to learn as young adults that they needed to go visit a dentist and have their dental care still looked after. And so the concept was really good. So this started off with kids in grade 9 and 10 in 1981. And I do feel, and I bolded that, but paid by per capitation for a reason. Because in my reflection and going back to do this PowerPoint, I do feel that this is when a seed was sown, possibly with private practice, that, oh, the government will pay us to do this work, X number of dollars per child. Because that's the 50% of the children who went to private practice, they were paid X per child. So that's paid by per capitation. The other 50% of the children stayed in the dental plan, and many of the high schools had brand new clinics built in them. I was lucky enough to work in Newtown Collegiate in Saskatoon, and it had a brand new beautiful clinic built in it with a reception room and everything. And the kids would come for their dental treatment, and you give them their slip to say that they'd been to the dental clinic, and it worked just fine. And again, that everything was monitored quite readily. There was still a quality assurance program in place for this. And when they compared the dental plan and the private practice, I mean, you could see clearly that the dental plan was a bit better at seeing kids more than once a year compared to private practice. So by year 3, we were seeing 98% of them, and private practice was seeing 81%. The dental plan was completing 93% of them and 77% by private practice. But they only did the fully completed after the first year. Then they didn't monitor that anymore, which was a little bit interesting because it certainly was still applicable to the dental plan. It just wasn't applicable to private practice. Because we were seeing adolescents, they decided that they needed to do a periodontal survey. So they did do that in late 1982 and early 1983, and they looked at 400 adolescents. And what they found is 92% of them had gingivitis. 4% of it was severe. 74% had calculus, and 3% had bone loss, which I think is quite shocking already at that age group. So anyways, clearly we needed to have hygienists because that needed to be dealt with. So they did actually implement a program at SciAST. It was called SciAST by that time. So in 1982, there was a 7-month program implemented to train dental nurses to become dental hygienists. So you could get a leave of absence from your dental nursing job, go to SciAST if you were accepted, take the dental therapist specialist course, and then you'd be dually trained at the end of that. So you'd be both a dental hygienist and a dental nurse or dental therapist. And if you got one of the positions that was offered within the Saskatchewan dental plan, then you were called a dental therapist specialist. That was a classification. And you had an 8% increase in pay then over a dental therapist. So that was a good thing. And that was in place until the end of the dental plan. And it's why we still have so many dually trained people in Saskatchewan, which to me is perfect. It's just ideal. Continuing education was always stressed. It was always important in the dental plan, just like prevention was. And so there was often hands-on courses provided in the summer. And those might be at the 10-chair clinic in Prince Albert or at Wascana. There was also theoretical classes offered during the summer and a variety of topics. I just put a handful up there. So oral diagnosis, forehead dentistry, effective communication. They were teaching us how to do good PR to sell the dental plan. Stainless steel crowns, anterior restorations, etc., etc. Continuing education was also accessed through the Public Service Commission because, again, we were government employees. And so we could access all the Public Service Commission courses on a wide variety of things. And regional office usually held 2 or 3 meetings a year, and continuing education was always part of that. So it was always stressed. It was always important. It continues to be important for dental therapists. And so glad to see that the Dental Therapists Association is continuing on that rich enrichment of professional development. So this is an important evaluation to know about. It's the one that really set the tone for the success of the dental plan. There's no two ways about it. When I was in school, there was lots of talk and, radio talk show hosts and newspaper articles about these 2-year wonders. How are these 2-year dental nurses who are going to be trained to do dentistry in 2 years when it takes dentists 5 years, which of course is what it took back then. And there was lots of concern about the quality of the work and how efficient we were going to be and could we catch up in the backlog and see all these kids. So this evaluation absolutely squelched all those concerns. So the 3 researchers who were very well-respected scientists came and they evaluated the dental plan in 1976, and they looked specifically at amalgam restorations, crowns, and radiographs. And they found that of all the amalgam restorations that they looked at, they were far superior in most cases, way better than average than private practice. The crowns were about the same, and 80% of the radiographs were acceptable. And they couldn't go into private practice to compare those radiographs, so they were quite happy with that. And they said the combined quality and coverage of the dental plan after 2 years of operation was very impressive, and they were extremely happy. And while I didn't put it on the screen, they were also commented quite widely on the children. So again, the children would pop into the dental clinic. Oh, who are you? What are you here for? And they'd be in the chair with their mouths open before the evaluators even had a chance to tell them what they were there for. So they were very impressed that the kids really kind of like coming to the dental clinic. They certainly weren't afraid. So by 1987, there were hundreds and hundreds of staff employed in the Saskatchewan dental plan. So not just dental therapists, there were dental assistants, there were administrators, there were support staff, there were dental technicians, there was head office staff who did data pieces, who did warehouse pieces, who did lab parts. And we were organized in 6 regions and always have been. If you still licensed for the Dental Therapists Association, you know that you're asked to just click off if you're in one of these regions. And they still exist from that perspective, from an organizational perspective. So there were 6 regions, and to be very clear, the Department of Northern Saskatchewan, while it did have the dental plan and it operated the dental plan, it was separate and apart. And also Swift Current, because it had its own dental plan for kids up to age 18, it wasn't until 1981, I believe, that they actually were rolled fully into the dental plan, because by then we were seeing most of those age groups. But Department of Saskatchewan still stayed separate and apart. So sadly, there was a change in government about 1982, and the Progressive Conservative government came to power, and they were quite focused on privatization. And so they did eventually privatize the Saskatchewan dental plan. And they go back to the adolescent program where the seed could have been sown that the government would pay private practice dentists X amount of dollars to treat a child in the dental plan. I think they saw that as an opportunity for the future as well. So on June 11th, 1987, over 425 Saskatchewan dental plan staff were fired. And they all received letters to report to major ballrooms in the major hotels in most of the big cities. And they were told to wear their uniform, and they were fired en masse. And it was devastating. It was absolutely one of the worst days of my life. And I, at the end of the day, had a job, but it was very traumatizing and very upsetting. When all those people were in the ballrooms getting fired, there were 18 dental therapists throughout Saskatchewan who were in another meeting, separate and apart. And we were getting letters saying that our position number, not us as people, but our position number had been retained. And we would now report to work on September 1st, 1987 as a dental health educator. And we all thought, what is a dental health educator exactly? We're dental therapists. We drill and fill. We teach people how to brush. What is that? So actually, the 18 of us that were behind, we actually did help do all the inventory for all the dental equipment, and everything was eventually sold. So all the dental equipment, all the supplies, everything was all sold. And still to this day, you can walk into a podiatry clinic or whatever, and you'll see an old orange dental plan chair there. But nonetheless, it was a very upsetting, devastating day for everybody involved. So again, there was a change in government around 1991. And the NDP government came back into power, and by 1993, they fully eliminated the children's dental plan. So they totally ceased for it to exist. And while it existed from 1987 to 1993, again, the public, it was okay. You could take your child to the dentist, and your treatment was free, and that's great. But again, as soon as we know that we have to start taking children to the dentist, The 25 to 30% of the population of kids who really need that dental treatment, they don't get there. Through no fault of their own, it's just the challenges in life. And so it's unfortunate, but that is exactly what happened. And then the oral health started to get poorer. So when the children's dental plan was eliminated, again, to be very clear, it was eliminated in the 6 regions that used to operate the Saskatchewan dental plan. There was still, to this day, a children's dental program in the north. Right at this point in time, it's very hard to find dental therapists to work in it, though, but it remained as a children's dental plan. They did lose some staff for sure, but they retained their concept of a school-based dental program for the north. So this is just a couple of slides to show charts to show the children's dental plan health outcomes. So these years here are all dental plan years, and this is when the children's dental program took over. So there was an immediate drop of participation from 88% to 81%, and that really just kind of plateaued off and went down to 74% the last year of the children's dental plan. And likewise with the improvement to the DEFT of 6-year-old children, all of this progress in reducing dental disease, this all occurred right down to here in the dental plan days. And in the children's dental plan, it pretty much plateaued right off at 1.2. It didn't really get any better than that. That's as good as they could get. And that's just seeing only a handful of kids too. They weren't seeing the 91% of the kids that we were seeing. So actual Saskatchewan dental plan health outcomes. So what were the good things the dental plan did? And these are not disputable. These are in annual reports. So the average DEFT, DMFT of a 6-year-old child started at 6.5 in the very first year of the dental plan, and by the time it ended, we were down to 2.8. Sorry, that's wrong. Yeah, 2.8, that's right. So almost a 60% reduction in dental disease, and that's pretty significant. We started in 1974 with only 12% of children being cavity-free at 6 years of age, and increased that to 39% by 1987. The DEFT of a 6-year-old in 1974 was 5.61, and we reduced that almost by 50% to 2.63. And again, it was the last time it was reported was 1985-86, because that's the last annual report that came out. And if you don't remember anything about this presentation, remember this, because this was for sure what did the dental plan in. So in the annual report of 1974-75, it concluded that the average cost to deliver those services per child was $158.29 with a budget of $2.8 million. And we were treating only grade 1s then, so not all those age groups. By 1985-86, which this is not the last year of the dental plan, so it would have been less even the next year, the average cost per child was $91.98 with a budget of $18 million. But we were seeing over 167,000 children during that time frame. So this is a very low cost when you consider all the infrastructure involved in delivering this program. And again, we know for a fact it was a backroom handshake deal between the government of the day and the College of Dental Surgeons Saskatchewan reps that they could provide this same treatment at a cost of X per child, which was less than $91.98. And that's exactly what happened. So remember that $91.98. That's what it cost to treat every child in the dental plan in 1987, 167,000 kids. That's a really good deal. So again, participation outcomes, again, going back to the first year, we only saw grade 1s, we saw over 13,000. And by the last year, we were seeing over 167,000 kids, age 4 to age 16. In the 74-75 year, grade 1s, 76% of the kids were enrolled. So people were a little bit hesitant right off the hop to enroll, but 76% is pretty good. By 1986-87, the enrollment of kids was 91.5%, which is significant, and we maintained that at a high level for quite a while. In the early years of the dental plan, although we did see Indigenous Nations children, the first couple of years they weren't reported because it was small numbers. But in 1977-78, they did report it, and they do know that 30% of the eligible Indigenous children were enrolled, and that increased in 1986-87 to 63% of the Indigenous children being enrolled. And again, to be clear, those would be children who were living off their First Nation community. They'd be in towns and communities and city schools and that kind of thing. So at the end of the dental plan, July 30th, 1987, this is a Star Phoenix reporter, Vernon Clements, who kind of tongue-in-cheek said, why exactly are we ending this dental plan? It was a good thing and people liked it, and we know it's all politics. So it was good to have that affirmation that people knew what the deal was. Quality and completion outcome, this was important to the dental plan. Again, I go back to the 2-year wonders. How are these dental nurses with 2-year training going to catch up on all this backlog of work for all these children? And do we know that all their treatment is fully complete? They didn't just see them for a prophy and a fluoride treatment. So they implemented the 99999, the 59 code, and we had to put this for every child once we completed all their treatment, all their exams, all their x-rays, everything. The 99999 was written down for every single patient. And they did actually monitor this the whole time of the dental plan. They stopped reporting on it in 1982 because then they knew that 91% of all the enrolled children always had their treatment completed. That's a very high number of children to have their treatment completed when you consider even then people moved around from place to place, and it was hard to find everybody sometimes. This is just a snapshot of the SGU collective agreement, in which listed dental nurse as one of the classifications and what their pay was. And I'm going to show you what that actually amounts to. So I couldn't get it right back to 1974 when we started, but in 1977, the monthly salary at the top end was $12.94 a month, or $7.96 an hour. And in 1979, the monthly wage was $13.87 a month at $8.53 an hour. And I think, as I remember correctly, in 1987, I think we were making around $17 or $18 an hour when the dental plan ended. The work week was kind of funny, 36 and a quarter hours, and we worked from 8:30 to 12 and 1:15 to 5. And of course, that has now changed significantly over the years, but that's what it was back then. So I talk about the Saskatchewan Dental Plan, and that was its name for a few years, but eventually the name did change to Saskatchewan Health Dental Plan in 1978. So it's called both. Typically, it's just called the Saskatchewan Dental Plan, but the official name is Saskatchewan Health Dental Plan. In 1981, the Saskatchewan Health Dental Plan also implemented, in addition to fluoride mouth rinse programs, a full dental sealant program. So we had been using dental sealants up until that time, but they fully implemented in 1981, where they had set criteria that these are all the conditions in which you have to place dental sealants, and we did that. It's also the year which, as I said earlier on, that the Swift Current Health region was fully absorbed into the Saskatchewan Health Dental Plan. And also, interestingly, in 1982, the Saskatchewan Health Dental Plan assumed administration for the Supplementary Health Benefits Dental Plan, as supplementary health data was reported until 1987 in the last annual report. Student fees, again, in 1974, it cost my family approximately $455 to send me to Wascana to become a dental nurse. And this is, was a lot of money back then. It seems like nothing now. But I remember how hard it was for my family to get that $455. And again, you can $220 for tuition, $15 for registration, $150 for books. We had 2 books the whole time we were in school. The rest was all handwritten notes. There was a student fee and, of course, lab and uniform costs. And so the beginning salary approximately was about $600 a month, or $3.70 an hour. So just kind of interesting. From a legislative perspective, to start the dental plan, the government had to pass the Dental Care Act, and that was done in 1974. It's still in force today. The Saskatchewan Dental Nurses Act was implemented in 1973, and that was very forward-thinking of all of our leadership in the dental plan and the government of the day. They did not want us to be under the umbrella of the College of Dental Surgeons of Saskatchewan. They wanted us to be free and independently regulated, and we were from 1974 on. So the Dental Disciplines Act that came in 1997, while it provided that umbrella self-regulation for dental assistants and hygienists and technicians as well, we had that from the get-go in 1974, thanks to forward thinking. That act was rescinded in 1981 and was replaced by the Saskatchewan Dental Therapists Act. And that's when our name changed. So that's when we stopped calling ourselves dental nurses and we were called dental therapists. Whereas the federally trained dental therapists were always called dental therapists. And of course, the Dental Disciplines Act in 1997, it didn't change much for us because we were already self-regulating, but it did very clearly articulate our scope of practice, and that was very beneficial because it clearly stated that we could communicate a finding of dental caries or abscesses, which is diagnosis. Again, the dental plan being very good at evaluation, they did a very good survey on the dental sealant program that was implemented. And the researchers of the day found that 79% of the sealants that applied were there 3 years after application. 99% of them retained after 1 year, 97 after 2. There was a 75.5% reduction of caries prevalence in 6-year-old children. That's huge. And that, if you go back to those charts, went from 6.5 to 2.8. That's how we did that, is through the use of dental sealants. And 20 to 30% reduction in one-surface amalgams as well, because now they were sealants and not cariously restored teeth. The data confirmed that dental therapists in Saskatchewan have an excellent record with sealant placement in children, and there's enough scientific evidence to recommend sealing incipient caries, which I think is maybe still controversial today, but I know in the Saskatchewan Health Authority, in the Enhanced Preventive Dental Services program, we do recommend sealing incipient lesions. So after the dental plan is over and done, there's still people researching it today. There's a wide body of research on there, but this is one of the more interesting ones. It was from the Economics Journal of Saskatchewan. It's written by Stephanie Ratsinoff. So it said public acceptance was high, 80% enrollment in eligible groups, and its main strength, it was school-based. We went school to school to school. We were client-focused. People, for the most part, didn't come to us. We went to them. Very cost effective. Now, her numbers are a little bit different than what the dental plan annual reports are. She has the 1974 cost as $341.89 per child, but the 1986 cost is still the same, $91.98, and that's a ridiculously good bargain. The high quality of service delivered by dental therapists must remain one of the hallmark achievements of the dental plan. The combined quality and coverage of care achieved was impressive, and there is little doubt that the dental health of children greatly improved since its inception. And certainly the Saskatchewan model was the flagship of dental public health in Canada, perhaps the world. It has demonstrated how remote populations could be reached with dental treatment, how staff need to be only educated to the level required, and how inadequate caries may be reversed. So again, a retroactive study, Saskatchewan school-based program, again studied just fairly recently. This is in 2016. And it clarified, again, only school-based programs staffed by dental therapists ever to exist in North America. It redefined the problem. It was not the lack of dentists that mattered, but the lack of care for children. In other words, the goal was to provide care to children, and all feasible means should be used to satisfy this end. We went to the kids. They didn't come to us. School to school, community to community. That was really a success. And again, the evaluations I've talked about, the very first one, they did a general service dental plan performance, 1974 to 1987, which was very well done. The Pitt and Fisher sealant, the periodontal survey, the phone survey, everything indicated high quality. So the majority of Saskatchewan citizens were very happy with this program, while a minority of the Progressive Conservative government was not. The minority decided what was best for the majority, and that's typical what happens in political situations. So in the 13 years the Saskatchewan Health Dental Plan existed, it improved access to dental care for kids by providing services at local schools with 90% or more participation. It absolutely reduced dental caries through effective preventive procedures. It provided quality restorative care equivalent to what private practice could provide, and resulted in more cost-effective oral health care than traditional private practice offices. So again, why was it so successful? Treatment done by the dental therapist was high quality. Children had no fear of the dental clinic or personnel and considered it just a part of school. Dental therapists were well trained to provide prevention and treatment services. And again, remember, we weren't doing the full meal deal that dentists were being taught in 5 years. We were taught very specific techniques, and we did hundreds of them before we ever left school. And that's a fundamental difference. Equipment and supplies were coordinated and consistent, so what we used at Wascan or SIAST is what we used in the field. The dental team delivered services to each local school and community in the province. The care was accepted and appreciated by parents. Continuing education was consistently provided. And this bold and innovative plan by Saskatchewan Health serves as a model of what can and should be done to address the dental health of today's children. And sadly, I'd have to say, I think that still exists today. We still need to be having something like this in place for children who are falling through the cracks, especially. So these are just some, again, from annual reports, some early pictures of the dental plan. So it shows kind of the lab and the warehouse and the equipment technicians and some various restorative procedures. And again, prevention. Prevention was absolutely important in the dental plan, and it was fundamentally why we were so successful in preventing disease. So these next few slides are just the millions and millions and millions of services that were provided over the 13 years of the dental plan. So contact with parents, there was over 3 million contact with parents in person, by phone, by letter. There were over 2 million diagnostic services, so exams, emergency exams, impressions, etc. taken. There were over 1.7 million x-rays taken of a variety of kinds, bite wings, etc. There was almost 5 million prevention sessions done, and that could be one-on-one, it could be with a parent, it could be classroom, it could be a variety of prevention activities in the community. Over 4.8 million, almost, well, like I say, close to 5 million. For fillings, whoops, sorry, I'm going to go back there. Sorry about that. Clicked a little too fast. So for fillings, we did over 2.1 million. That could be a composite filling, could have been an amalgam, could have been a stainless steel crown. It was all counted as restorative. Pulp treatments, over 135,000 pulp treatments. Again, pulpotomies, pulp cap. Over 236,000 surgeries, and that could have been extraction of deciduous teeth or permanent teeth. Our the dentist that worked in the dental plan did some of that. There were some frenectomies done and some other surgeries done also that our dentists did. We were trained to do space maintenance, so we did over 88,000 space maintainers. Again, could have been a crown and loop, could have been a lingual arch. And there was over 107,000 referrals to private practice. Now, this could have been for something that was beyond the scope of the dental therapist to do, could have been behavior, and oftentimes about 10% of those a year would have been like the after hours, weekends coverage that private practice did for the dental plan. So 50 years later, I'm leapfrogging way ahead from the end of the dental plan, 1987 to today. There's a whole professional development session that can be done on what happened to the dental health educators. So when we became dental health educators, we thought, hey, what the heck are we going to do? We still exist. Dental health educators still exist in the Saskatchewan Health Authority and Dental Public Health. They have delivered multiple wonderful programs to the public over the course of that time frame. And that's, like I say, a whole professional development session for another day. But leapfrogging to today in 2024, 50 years later, they haven't gotten rid of us. We're still here. We're going strong. There's training back for dental therapists, and so we're good to go, I think. So what are we doing 50 years later? Well, there are still school-based and primary healthcare dental programs and clinical services delivered in Athabasca Health Authority on Indigenous nations for Indigenous Services Canada and in the Saskatchewan Health Authority. They also are employed, if we think of Section 25, in the Dental Disciplines Act, they're also employed in post-secondary education and private practice, which in private practice is by far and away where the majority of dental therapists today are employed. And we really do need to change that and get them back into public health. And we do know in 2024, there's 161 licensed dental therapists. So where are they all working? Well, some of them work for Indigenous Services Canada, delivering COHI and other preventive promotional services. This is just a Northern Oral Health and Wellness Day that was done in La Loche a few years back. These are all dental therapists in the picture. They volunteered their time to go to La Loche and deliver free dental care for residents in the community. The Northern Oral Health Working Group is a collaborative group of mainly dental therapists who get together and they work and discuss and collaborate on ways to improve access to care for residents in the North. It is a very collaborative group. It's lasted a long time. And there are several pictures of this, mainly because people sent them to me, so I put them in here. But they are a really good group, and they do a lot to support the oral health of northern communities. And you can see we're all working very hard there in La Ronge on the boat. I was a part of the Northern Oral Health Working Group, so I know that they do really good work. Again, working very hard on the boat. And the members change over the years, the people come and go, but very, very important group. In the Saskatchewan Health Authority, again, some of these are a little bit older, so don't criticize us too much on the infection prevention control because they're not always right current with that in these pictures. And as you can see, they're a little bit older. But here you see, prevention, anticipatory guidance, oral hygiene instruction, prevention, 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 including the parents. This is actually from Saskatoon. That's our West Twins Dental Clinic and our White Buffalo Youth Lodge Dental Clinic, which are under public health in the SHA. Dr. Brothwell is up in that second photograph there if you want to see if you can pick him out. This is just myself and Cindy Reed and Glenda. I was getting my long service award. I want to say that was at the Olympics conference in Regina. Not sure how many years ago. Indigenous nations, many dental therapists work on Indigenous nations, doing a good job. Again, lots of work in the Saskatchewan Health Authority. Post-secondary education. Thank heavens, we're now training dental therapists again. This is a lovely photograph of the Northlands official opening. And just look at all those nice new spanky new dental therapists. It's just heartwarming to look at. It makes me smile. Again, post-secondary education, there are certainly dental therapists working at Saskatchewan Polytechnic, at the College of Dentistry in Saskatchewan, the Prince Albert campus, and private practice. Again, that's where most of them are employed. Thanks to everybody who sent me photographs for that segment. I really appreciate that. And I'm just going to briefly mention the Saskatchewan Oral Health Coalition. So I helped found the Saskatchewan Oral Health Coalition in 2010. It is now a charitable organization in 2024. And we work as a unified voice, and we do oral health literacy, provide dental treatment, the payment of dental treatment, and oral hygiene supplies to vulnerable populations. If you'd like to donate, you can certainly talk to me about it. You can Google it. You can look it up online. There is a donation page right on our website. But this is something that is really important. It's come out of all my 50 years of work in dental public health. And it is still something we need. We still need to have a charitable organization that supports people, dental plans aside. Saskatchewan is dental therapy country. This is a poster that was actually developed and handed out at the very end of the dental plan. And it was given to the public and to our patients and to teachers and staff in school. And I truly believe Saskatchewan is dental therapy country in Canada. I hope it continues in Saskatchewan. I hope it spreads across Canada. And I hope it continues as long as the sunshine and the river flows. This is actually just at the back of that particular poster. I'm just going to read the reason why the dental plan ended, which is the middle part. Why did this happen? It wasn't to save money because the 175,000 children aged 4 to 13 in the plan are now going to be treated by private practitioners for about the same cost. It wasn't to increase accessibility because utilization is expected to decrease under the new scheme, which of course it did. It wasn't because of poor quality care, because the plan was famous for high quality care and treatment. And it wasn't because the public wasn't satisfied with the plan. The children and parents liked it. We all know why, what's left, don't we? Politics. And sadly, that is also what ended the training at the National School of Dental Therapy in Prince Albert. So politics does go hand in hand with dental therapy. And we have to be really cognizant of that at all times. Thank you. I hope you find this to be an accurate account of the Saskatchewan Health Dental Plan. If people have questions in the future, they can certainly contact me. All of the references and resources I used, again, as I stated, are all on the Saskatchewan Oral Health Coalition website. You just have to Google that and go to resources, click on History of the Dental Plan. And all the pictures came from all these references and the annual reports of the dental plan. I thank you very much for your time. And again, get in contact with me if you need to talk to me about something.